to talk about mitral prolapse. We will cover definition, etiology, pathophysiology, difference between mitral valve prolapse and flail, clinical symptoms, diagnosis, and treatment. So first of all, the heart has four chambers. We have the right atrium, right ventricle, and left ventricle. We have tricuspid valve located between the right atrium and the right ventricle, mitral valve between left atrium and left ventricle, aortic valve between the aorta and left ventricle, pulmonic valve between right ventricle and pulmonary artery. The cycle starts with desoxygenated blood coming from superior vena cava and inferior vena cava into the right atrium, and then it goes into the right ventricle through the tricuspid valve, and it passes through the pulmonic valve into the pulmonary artery to the lungs where it gets oxygenated, and then it comes back into the heart through the pulmonary veins, pouring into the left atrium, and from the left atrium it passes to the left ventricle through the mitral valve. From there, it goes into the aorta through the aortic valve, and it goes into the organs and the tissues, giving us oxygenated blood. And the organs and the tissues, they take this oxygenated blood and they drop this oxygenated blood into the venous system, and the cycle repeats itself. So mitral valve prolapse, it's a structural defect of the mitral valve which results in these mitral valve leaflets bulging into the left atrium during systole, and it's a very common cause of mitral regurgitation. So, etiology, it's mostly idiopathic. It can be caused by connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, Fragile X syndrome, or myocardial ischemia or myocardial infarction, which leads to a rupture of chordae tendineae and eventually leading to prolapse of the mitral valve. Acute rheumatic heart disease, infective endocarditis can be a cause as well, and autosomal dominant polycystic kidney disease. The most common pathology in the case of mitral valve prolapse is myxomatous degeneration of the mitral valve, which means eventually the deposition of glycosaminoglycans in the mitral valve leaflets due to a primary disease or connective tissue disorder. And this one, it will lead to formation of a long, floppy mitral valve leaflets with excessive valvular tissue. So the mitral valve annulus becomes dilated and the chordae tendineae becomes elongated, and they may rupture eventually, which will lead to prolapse of one or both of the mitral valve leaflets into the left atrium during systole, and this one is without rupture. The leaflets may also exhibit fibrous thickening at regions where they rub against each other, and if the prolapse happens without the rupture of chordae tendineae, they billow into the left atrium, and they cause mild to moderate mitral regurgitation. If the papillary muscles become severely ischemic and the chordae tendineae rupture, they cause flail into the left atrium, eventually causing severe mitral regurgitation. So here is a picture of parasternal long axis view in echocardiography. We have here the mitral valve leaflets billowing into the left atrium. This one is without the rupture of chordae tendineae, and they are displaced more. It's like they're displaced above the annular level into the left atrium. And for the prolapse, here we have the mitral valve leaflets bulging into the left atrium. Here we have also a picture showing the difference between prolapse and the flail. So the flail, as I said, it's due to a complete rupture of chordae tendineae, and it leads to this mitral valve leaflets completely going into the left atrium, while for the prolapse, it's just bulging into it. Clinical symptoms. Most patients are asymptomatic, especially at the beginning. Rarely we will have atypical chest pain, anxiety. In case of complications, patient may have dyspnea, fatigue, cough, syncope, and palpitations. As auscultation, we will hear a mitral valve prolapse click, which is a high frequency mid systolic till late systolic. It can be a click, which is best heard in the mitral region, and it may radiate also to the axilla. And patients with severe mitral regurgitation, we may hear S3 as a result of a left ventricular overload. For diagnosis, on ECG, it's mostly normal. For the main diagnosis procedure is transthoracic echocardiography, where we will see displacements of the mitral valve leaflets during systole more than 2 millimeters above the mitral valve annulus in the parasternal long axis view. We have two, like, not classification, but two variants. Either is going to be classical mitral valve prolapse, which is more common, or non-classical mitral valve prolapse. So for the classical, we will see leaflet thickening more than 5 millimeters, and the non-classical mitral valve prolapse leaflet thickness less than 5 millimeters. We can use also transesophageal echocardiography, especially intraoperatively, to guide for the mitral valve repair procedures. For the treatments, if we have a severe mitral valve prolapse and eventually causing severe mitral valve regurgitation, either we will choose mitral valve repair or replacement depending on each case. We can use beta blockers for symptoms relief if atrial fibrillation is present, because it's common as a complication of mitral valve prolapse. Then we treat it using race control and rhythm control therapy. I have another video for atrial fibrillation treatments if you want to check that. If there is a history of infective endocarditis, we may add antibiotics as a prophylaxis. So for complications, as I said, atrial fibrillation is very common. Ventricular ectopic rhythms, in case that there is this case, we can use beta blockers for symptomatic relief. Stroke and transient ischemic attack can be a complication as well. Infective endocarditis and eventually right heart failure due to left-sided heart failure. And that's all for today. I hope it was useful. Thank you.